Our first speaker is Tom Fagen from Denver, who will be speaking on 3D multimodality road mapping for congenital interventions.
Oh, so that's good. Okay. Thank you, Craig. Thank you, Girish. And thank you for the conference committee for the opportunity to speak. Here's the disclosures. So, purpose. Why would we talk about using three-dimensional imaging on top of what we normally do? Fluoroscopy and angiography, as we all know, is a standard for guidance of our complex cardiovascular interventions. And we've all been trained to do this as our standards. We feel fairly good about how we do it. Well, the whole thought is, can integration of the three-dimensional image data sets with fluoroscopy, can it make catheter guidance more facile, improve the efficacy, and enhance the safety of these procedures? There's a little bit of data that's been published on the topic, but clearly we've got a lot to still go with it. So the goals that you would think of right off, at least the immediate ones for this type of approach, is to improve the confidence and the efficacy of the interventions, number one. See then overall if we can reduce radiation exposure, contrast dose, and procedure times. The modalities I'm going to speak about, and within 12 minutes, hopefully I can cover a lot of this to give everybody a flavor of what we do, but it will be pretty quick, so hopefully everybody can stay with me with this. We're going to talk about three-dimensional angiographic reconstruction, road mapping, as well as CT-MR data sets that can be imported. And lastly, I was going to talk about three-dimensional transesophageal echocardiograph. Not going to speak too much, and I took some slides out about the basics of generating three-dimensional reconstructed images from rotational angiography. Hopefully everybody's seen enough of this and I didn't spend time going through it. But in our lab we're using, we have a 4-second acquisition that covers 240 degrees, and you can see an image of this, which is a simultaneous injection into the SVC and IVC of a patient with a Fontan. And as noted during the rotation, just proximal to this RPA stent here, and you can see on then the reconstructed image data set, there's stenosis proximal to that right pulmonary artery stent. So then using this three-dimensional reconstruction, since it's acquired from the actual angiographic equipment that we're using, it basically is automatically registered and it's aligned. So instantaneously, once you've created the images that you want, you can actually have them as a roadmap. We haven't gotten to the point yet, and still not as comfortable that we would just use the roadmap by itself. Here, this is a confirmatory angiogram showing placement of our and positioning of this new stent proximal to the stent that was previously placed. And here you can see the confirmation angiogram running a little bit slow, but actually has the anatomy and pretty well down as far as the registration. So again, showing one of the advantages of the system is that then to really check the position of the stent and make sure that's not going to be interfere at all with the glenanastomosis, instead of shooting more contrast and using angiography just under fluoro using a roll, we use a three-dimensional image to actually help us with this endeavor. So hopefully, again, over time, saving contrast, saving radiation. Here's an image after the stent has been placed, again showing that again, using this for guidance, either a catheter manipulation device delivery can be helpful. Our data, this was just presented last week by our fellow Dr. Abu Hassim at the SCANI meeting, but so far we've had 88 3DRA studies that were performed in 86 patients and 90 interventions performed with those between August of 2010 and March of 2014. And a breakdown is here. I'm not going to go through the entire breakdown, but again, most of what you would expect for this technology is non-beating structures, because motion really interferes with the reconstruction. So most of this is in arterial and venous structures. Overall, though, and it's a very subjective measure of how well this technology has helped us during these procedures, the primary operator evaluated each of these procedures after the case, and 64% wound up being superior. There were 18, about 15% or so that showed no benefit. There were only 6 that were inferior, and one we listed as disadvantageous. The reasons for that we have listed here. Some was just the specific anatomy, and this data set has our entire experience with this, so learning curve, all of it is in here. So with it, we learned that there's some specific lesions that it doesn't work very well for. Here we had one case that was a very distal branch pulmonary stenosis. Differentiation and segmentation of that made it fairly difficult, so that's why one of them that was inferior. An arteriovenous malformation, because of the quick return into the pulmonary venous phase, made it almost impossible to tell the difference between the artery and vein for the reconstruction. As with all 3D RA, if you don't get uniform opacification of the desired structures, it also was a hindrance. We had a couple of cases. One was an example would be a Fontan with collateral flow that was non-opacified from some of the branch pulmonary arteries. And early in our experience, we're using a more cumbersome system that we had to segment in, and the segmentation allowed bleeding where we would try to paint in structures. So that one actually we listed as being inferior as well. The disadvantageous rating for one patient, there was no harm done to the patient necessarily, but we had one, when we moved to our new system, we had a glitch in the system where we created the image and we lost it twice before we could register it. So just the time under anesthesia, we counted that as disadvantageous. So moving on a bit, talking about MR and CT, three-dimensional data sets that we can import. This is a system that we call Heart Navigator. And here, as you can tell, just as the three-dimensional data set is imported into the system, to segment this is actually working mostly with an auto segmentation here. This is a patient that's got a stenotic RV to PA conduit that's in purple, or the pink color. The RV is in here now just so that everybody can get an idea of the structures. But you also get with this, as you construct these, do the segmentation on this, we can swap between the three different planes of the coronal, sagittal, and axial. And here we can actually change, if we didn't like the auto segmentation, we can actually go through and segment ourselves, which here we're showing that we're going to start putting a little bit more of the color and filling in a little bit more distal to the right pulmonary artery. But as we do this, if you notice, the three-dimensional image is changing as well up here in the top corner. If we don't like it, we can erase it. We can continue segmentation with this. We also do this trachea, and for the most part, most of our registration, we have used the trachea for registering this data set with fluoroscopy, and I'll show you the example of that here in a second. So here in yellow, you see on the fluoroscopic monitor, on the FlexVision, you see the trachea that's been reconstructed, and we use this with two-spot fluoro, angled 30 degrees from each other. Align the trachea with the airway, and at that point, then our system should be registered. And here you can tell after registration with our movement of the gantry, then that will move the image as well. And typically we use an outline form so we can see very clearly the catheter manipulations underneath. Here's an example. It's the same patient that we had the stenotic RV to PA conduit with the frame on the left. Here's a confirmatory angiogram in the conduit showing that the registration and the anatomy is quite favorable for using this. And then the frame on the right shows stent delivery prior to implantation of a transcatheter valve. This is an example of an MRI, and this is actually looking at the anatomy in Heart Navigator after this aorta has been segmented. There's a very complex aortic arch, and actually the smaller of these vessels that you see, the one with the head and neck vessels coming off of it, here as this rotates around, it should spin. There we go. This is the native arch up around the top. This is a 23 millimeter jump graft that was interposed between ascending and descending aorta, and you can tell even with this complex anatomy that that kink in there was causing hypertension for this patient. We use this image in order to get and define our best projections for working angles before we even got the patient into the room. And then that looks like this here. So an outline form again of the very, very steep LAO and caudal position. You can see stent delivery. Again, we put it into the jump graft. Here is stent positioning, and then stent delivery is on the right. Other modes of registration, because we have found it cumbersome trying to use the trachea at times. Sometimes it doesn't show up as well, especially bigger patients under fluoroscopy. So especially patients coming in that are going to have an MRI or a CT procedure on the same anesthetic as the catheterization, we put fiducial markers down on the patient's skin. The cap that's in this one shown here is a vitamin E capsule. It shows up well under MRI. Then we switch this out for a radio-opaque marker in the cath lab. Here, we use it in a patient with pulmonary atresia intact ventricular septum after a Glenn. The green dots that you see here are actually the segmented markers that are now placed over the markers we see on fluoroscopy for registration. You can see how well the anatomy has lined up. So to date, 24 studies have been done, 11 of those CTs, 13 of them from MR have been performed on 24 patients, and 27 interventions have been performed during these dates. And again, the breakdown is here. Of interest, too, of the PA stents, 2 of these procedures were actually pulmonary artery reconstructions after the vessels had been occluded. We used the LEVA phase of imaging of CT to fill the distal vessels. So that way we could have targets to go after when we were actually making our run at perforating through the occlusions. Again, operator evaluation, 63% of the procedures were felt to be superior, 26 were felt to be of no advantage, none were inferior, and disadvantageous, again, was 1 for similar reasons as our last. Almost all of these are still, again, registration issues, and if they're at present, it still is relatively time-consuming process. Again, the trachea can be difficult, and our first patient, we used fiducial markers in the transport. One of the markers fell off, which then makes that clearly disadvantageous. We had segmentation difficulties in MR data sets in 2 of the patients, depending on how those were acquired, especially if they're outside studies. And one, I'm going to show you here, patient coughed after the registration and moved on the table, and also with a stiff wire in the aorta, you can see how that's distorted off the normal anatomy. So again, these are not real-time images, and anything that changes the anatomy or patient positions can throw this off. So lastly, I'm going to cover, hopefully very briefly, our work with three-dimensional echocardiography. And these are a little different than what we're used to, is actually very focused examinations, and used to visualize the lesions and the equipment assessment for delivery and for immediate results. It's set up in the echo specifically for optimizing the hand-eye coordination of the people performing the procedure, as well as used for aligning the devices. And this modality is real-time, and this will acquire images on the spot and show different changes. Quickly here to show you the setup of how what the system would look like. Once the transesophageal echo images are acquired, this is what the echo docs are looking at. And different than what they can even do, there's actually 2 other windows that can be used, and we can see 2 other windows of the 3-dimensional data set instantaneously. Here, this is looking at the ASD from the right atrium. This panel, we're looking at it from the left atrium, and here we're cut basically right on edge of the atrial septum. This image, the same, actually just demonstrating catheter passage through the defect. This system now is registered, you can tell, and it's an automatic process. This indicator down here, the system will actually, on fluoroscopy, find the head of the echo probe, and based on its position, that's how this image gets registered. You see this purple pie. This is the 3-dimensional data set will come out of this. So this is all, again, registered between both fluoroscopy and you get an idea of the 3-dimensional data set from echo. This is just showing then, using this to show the device being pulled back up into the septum. This is again looking from the left atrial side from the echocardiographer's view. As you can see, looking from the right atrial side, you can see the device is actually protruding through the defect a bit under 3D live as we do this. We actually re-advance the device at this point. And something else very helpful we found with this technology, an echocardiographer, the echo docs can do this as well, but here the interventionalist has control of these 2 other panels. Once this device is delivered, we're actually scrolling through this device in this panel using our cropping tools. Here you can see this GSO device and the atrial septum running right between both discs. And we can take this from one edge to the other to actually assess how well the atrial septum is encapsulated underneath both discs. Very quickly, I'll go through this one. This is a procedure where it was not, this technology wasn't necessarily necessary, but we used it to learn more about the system. This was a patient who has a 23 millimeter aortic CE valve placed in the tricuspid position. This is looking at from the right atrium down here in this top right panel. This we're showing that we can actually, demonstrating the tools that we have at our disposal. This window, again, controlled by the interventionalist, we're able to rotate this around. Now we're looking at it from the ventricle up, still looking at the tricuspid valve. And we haven't registered yet, but the C-arm video here correlates with what we would get from X-ray. And what we do next is from this view, again, at our control, we can crop through this to actually take out part of that ventricular septum to get more of an adequate view of that tricuspid valve from the ventricle. So again, modifying these images at the control of the interventionalist to help out with these interventions. This actually is, again, cropping once we actually aligned this data set here from the C-arm view with the fluoroscopic view. So we're a bit RAO and some caudal, as you can tell here. But again, to see the valve leaflets within the CE valve, the bioprosthetic valve, we're cropping down into it and actually cutting back into it so we can actually see the leaflets within the valve itself from this projection. Again, here now showing the delivery of the transcatheter valve into the bioprosthetic. Again, we could see this by fluoroscopy, but one thing to note is we actually can see then valve leaflets and make sure that gets incorporated into the position of the device going in. Lastly, again, trying to make this technology smart for the interventionalist, we can actually develop, actually deploy targets based on the echocardiographic information, either by X-plane or in 3-dimension. Here, this is information given to us courtesy of my partner, Dr. John Carroll, where a target has been placed on the ring of this mechanical mitral valve. You can see there's already 2 devices deployed for paravalvular leak, but there was one large one still left. And the target was placed both in 2 different planes. That actually shows up under fluoro, and you can see it here. So that way, both echocardiographically and on fluoro, you have a target to go for in order to pass the catheter through that. And here you can see demonstrated the catheter is passing through that same leak in the paravalvular region. This is actually showing it after the device has been placed, and the target still is aligning nicely with where the defect was. Then real briefly, we've just been using this for about a year, and during that time, because of contract negotiations, we actually were not able to use this for about half of this year, so only about 6 months worth of time. So I'm not going to, we don't have much to say about it because we actually use this for some indications we otherwise would not have. There's 3 Fontan fenestrations that we were planning to create in patients with PLE. We get into the lab and found out we had other things we could do rather than create the fenestration, but we did use it to guide those other interventions. And it's some of those that turned out to be not advantageous through this. However, we are still learning from this technology, and we think for certain lesions it's going to be extremely helpful. So in conclusion, using 3D multimodality road mapping, the advantages of these techniques are being evaluated still, and we're starting to document specific uses where they're helpful. I think we can better understand a 3-dimensional anatomy and the implications for intervention. Catheter manipulations and device delivery can be made more efficient. Lesions, both well-suited and ill-suited for these technologies, are being defined. Limitations of the technology itself are also being defined. Fluoroscopy, we're hoping, is a line again from Dr. John Carroll that hopefully we're making fluoroscopy smarter so that it helps us in our endeavors. And again, for those goals, I think we're getting to the point these actually, I think they will, as they continue, improve our confidence in the efficacy of these interventions. And the rest will take, we still need time and more experience to see if they're going to be truly that beneficial. Lots of people to thank for this endeavor, all my colleagues at Children's, and especially Dr. John Carroll and the crew at University of Colorado for helping us get involved, and then the folks from Philips. Thank you very much.